So welcome everyone. I'm Tekla Johnson, the director of the Firstborn Model Office here in Santa Fe, New Mexico at the Santa Fe Community College. This weekend-long symposium is happening through the hard work of a lot of different staff and contractors here at the community college and in collaboration with all of our presenters. And we're just also glad that you're here joining us, either here live today or watching the recording after the fact. The Firstborn model was established in 1997 in Silver City, New Mexico, and it's always had a medical director. Originally, that was Don Johnson, who was a pediatrician, also the husband of Vicki Johnson, the founder and creator of Firstborn. So he was the medical director for many years until the model came to the Santa Fe Community College in 2018. And for the past 2 years, we have had Dr. Amy Williams as our medical director. She's a pediatrician, local here to New Mexico, grew up in Albuquerque and graduated from UNM. So we're going to have her share today about her passion and experience connecting medical healthcare providers with home visiting. And as we wrap up, her presentation will be for about a half an hour. As we wrap up, we'll talk a little bit more about how she's been engaged in Firstborn and supporting home visiting through her expertise as a pediatrician. If you have any questions for her specific to healthcare providers and home visiting, please put those in the chat. We'll be answering questions at the end that relate to the topic today, talking about a couple ways that it's been fun to work with her over the years through the model, and then wrapping up. So your reminder came saying this was an hour-long session. It's more likely going to be about 45 minutes. So welcome to everyone, and thank you, Dr. Williams.
Thank you. It's a pleasure to be here. And as Tekla mentioned, I'm a medical director for the Firstborn program, which I've been with for 2 years now. And I'm also a pediatrician, and I've worked as a pediatrician for about 13 years now. And I am going to just share my screen, which is always so fun. And Tekla, you can tell me if it's showing appropriately or not. I assume you guys can see that. Is that
It looks perfect.
Perfect. That's always a good start when you can get Zoom to work with you for these. So I'm going to spend some time just sharing my own experience and journey and how I learned of home visiting through medicine. Obviously, this topic is very dear to me. I find tremendous value in community and the ability to spend time supporting those around. So I'm just very excited to share this with you. And let me see if I can get this to move. Perfect. So when I moved to New Mexico at the age of 2, my parents did not come with a huge family support. They came by themselves. And it was like many families experience. We had one working parent, and my mother, who stayed at home, she sort of experienced the isolation with 2 kids, trying to gain her own community through neighbors. And at that time, we didn't really have a lot of home visiting programs that were offered. She just really had to find that community herself that would help support her. And many of families that I see have that sense of isolation, especially first-time parents. And we all know that postpartum depression is huge, a huge issue. And really understanding how to raise children and the growth, the development, all of those pieces, as well as their behaviors along the way, it's really complicated. So at that time in the 1970s, there wasn't a lot available. And so my mom was really relying on pediatricians and neighbors at that time. And then as a teenager, I went to this wonderful community in Costa Rica for 2 months to help build latrines and do some community service. What I experienced over there, it was a very small community, not very poor, but they had generations of support living around. So we had, in my house that I lived in, there was a grandfather, grandmother, mother, two sisters, aunts, cousins, all in this one surrounding environment. And there was this community that was teaching the grandchildren all of the, aspects of growing up. They were teaching baking, all of the pieces that have the multi-generational community education model. And it was really fascinating to see, especially as a teenager, that that difference from what we were experiencing as I was growing up. As a medical student, I was able to go to Honduras, and what we were working on was a childhood malnutrition program. It was a project to look at how malnutrition rates were in different parts of Honduras. So there was a group of us that traveled through several communities, and we would go to each house and we would weigh the babies, measure them. We would talk to the families in their homes regarding their living situations. We could assess the surrounding area because we were right there. And that's really where I started to see the value of community outreach, and including going into the home, sitting with a family and seeing really a broader picture of all the resources that were available to that family, the limitations that they were having, and being able to kind of integrate into their life. It really provided me a much better understanding of the families and their community. And so as a pediatrician, I was able to work, my first job actually was with Baylor. They had a project called the Baylor International Pediatric AIDS Initiative. And I went to live in a small community. It's a country called Lesotho in South Africa. And my project was to work on maternal childhood HIV education and treatment. So we would do a lot of education and treating that population. And while I was there, I was able to travel to these really small communities. There was a lot of different clinics run by Red Cross, healthcare workers that lived in these small communities, hospitals, and I worked in an orphanage. And this picture is of one of the babies that I was working at in an orphanage that was in Mogotlon, Africa. And it was just beautiful because this orphanage had these beautiful babies, but HIV had unfortunately wiped out a lot of the generations in between. So there was a lot of parents that were lost, grandfathers that were sick and couldn't care for the grandkids. And so this orphanage was in a place where they could house that in-between place until there was a family member well enough to care for that community. And this, again, helped me to understand kind of the environment by being able to go out to these places, to go out to the homes and see the community. But also it helped me to learn what happens when there is a lack of support or a break in support on childhood health, on the development. As we all know, those first couple of years are so critical in the growth and development of kids. And to be able to see, malnutrition, the impact that has, isolation of kids away from parents, and what that has on the effect of kids. It was really empowering. And it was very helpful for me to understand that piece for just understanding how that impacts children as a whole. In general, and this is a picture of Lesotho as well. These are the houses that the families would live in. with no electricity. There was no running water. Heat was the fire that was in the middle of the house. They all had one room where everything was done in that room. But all of this really, just all of these experiences helped me to know a little bit understanding about the communities, the impact that resources and support have on them. And seeing that it happens in developing countries, but it also happens within our communities here. And so I think that was just a very helpful piece. Whee! Oh gosh, it's going so fast. Let's see. So when I came back to the US, apologize for that. I really wanted to reach out to our own communities again. So I started this newborn home visiting program in Utah, where I was a pediatrician. And the staff and I would go out for the first 2 well visits into the comfort of families' homes. It was both the one after they were discharged from the hospital and the 2-week well visit. And it really allowed families to stay at home because those first 2 weeks can be quite stressful, trying to get a new baby in a car seat, and then they poop, and then you got to change the diaper, and then you're late for your appointment. And it's really just that stress, never having the child on the schedule as the appointment is supposed to be. But it also helped me to understand where families were coming from, because I could see their environment, understand their support systems. I was able to tailor the treatments a little bit more individually to those families' needs. And so that was a very nice piece. It really helped me to understand the value of home visiting in general. And obviously, it's a very big passion of mine, as you can probably already tell. This is something that we used to do in the past. In the 1800s, house calls were how medicine was done. People were too sick to go anywhere. The doctor would come to your house. And as the clinics and the hospitals grew in the 1960s, the practice of house calls became less. And it became more efficient for the families to come to clinics to see the doctor. And in the 1960s, this is also when home visiting programs began to expand more in general. And with that change, that really started to make it less, the doctor had less time to spend with people in general. And one of the National Home Visiting Resource Center, they saw that there was at least 1/3 of patients that report spending less time, less than 10 minutes with their provider. And less than 10 minutes is really difficult for a doctor to really have an expanded, broad view of what's going on with that family as a whole. In addition, resources in that time frame is very limited, especially with developmental tools. The well visits, this provides us a really good, wonderful screening tool to identify risk. But often the resources to support families becomes a little limited in that clinical setting. And so it's really kind of hard to provide all the resources of psychosocial, developmental, behavioral, those pieces. We can only see and understand what is presented in the room as providers. So seeing that whole surrounding home environment and the community that surrounds that family becomes limited in the clinic. Providers really have to kind of navigate the whole health story of a child through storytelling, history, trying to collaborate that plan and develop some sort of care plan with a really limited time. And that's where I feel like home visiting is so important and something that we really need to be more collaborative with. It's a huge benefit, huge benefit. And it's for the same reasons that we're limited in healthcare. I feel like with home visiting, they're able to provide all these pieces that are being kind of limited and lost in that clinic setting. Home visitors in general have a time and to support, to educate, to listen to families. And I think that they're able to provide the needed education on concerns, especially like development, behavior, psychosocial pieces, that whole part that they can really see and support. And they're able to see the environment that the families are living in and the community surrounding it so that they can better support those pieces as well. I'm sure a lot of you have learned through this symposium how important there are the benefits of home visiting. And this is just a quote from the Pediatric Journal. And I'm sorry, I have two screens, so I'm looking over here sometimes. I apologize if it looks like I'm looking both ways, but this quote, and I'm just going to read it directly: high quality home visiting services for infants and young children can improve family relationships. They can improve school readiness. They help with childhood maltreatment. It improves maternal infant health outcomes, and it can improve family economic self-sufficiency. I mean, that's huge, right then, and that's incredible to think of all of those things that home visiting can support. I think that both the medical community and home visiting have similar goals, and I think both providers and home visiting programs are really trying to promote childhood health, and they're trying to promote well-being in general. So I think that both of them, and I apologize, this is moving faster than I am talking. Both the collaboration of both is very important. I think home visiting may be most effective when integrated with a family-centered medical home and a community-based comprehensive system. So when the two are integrated together, it provides a comprehensive system for families and for young children. And I think that's a very important piece. I think this is where the two communities can bridge between each other more. And I feel like this is an opportunity that I would like to see expand more. The National Home Visiting Resource Center stated that 38% of home visiting providers and pediatric providers communicate together. That's a third. And I think that's good, but I think it could be better. I think this is something where the ability to collaborate those two pieces, understanding what the home visiting programs are seeing, the risk that they're seeing, can really help providers navigate their care plan for those patients as well. And some of the reasons that I think that there's not as much of a communication were sort of described earlier. You know, providers may lack the understanding of the value of home visiting. They're limited. Healthcare workers are limited in time in a clinic setting, and so they just may not have the time. And I think the biggest thing is that if the two don't have the same goals and priorities, it may not provide the same message to the patient. And so that might be a conflicting piece. This is really why I'm very passionate about the Firstborn program. I really feel like this program has a research-based support on emotional developmental growth in that critical first years of development. The home visitors and I meet, which is really great. We meet quarterly to have question and answer sessions so that they have an opportunity to speak with a pediatrician about just questions in general that they're seeing with developmental childhood malnutrition, growth, that stuff. And I think the goal in general with the Firstborn program is to support raising healthy families, and they're able to provide the time to do that. It's also very community-based, which I love. As we know, families that are supported are really able to create healthy communities. And in working with families, they can develop goals as a team. It really reduces that sense of isolation for families, which I think is huge. And as we know, there's a big benefit to families. Sorry, I'm pressing my button and it keeps moving around. The benefits for family is huge, as I mentioned before. I mean, I think it's something where if a home visiting provider can intervene early, that really promotes supportive relationships. It reduces parental stress. It increases a positive experience in parenting as a whole. And I think those are a big part of what reduces risks in general for families. The the health outcomes are huge and positive. Being able to identify issues or risks early, that's a huge one for reducing potential outcomes like child abuse. And that's big. I think child abuse really does come from isolation, not understanding, becoming overwhelmed, postpartum depression, amongst many other reasons. And I think being able to see that early on and reducing that risk is incredible. Having the time to sit with a family and teach them the developmental tools for their child really improves their growth and their learning. It reduces potential bad behaviors, and we know the terrible twos and the terrible threes are really difficult. I think the terrible twos and the become even harder as the 3-year-olds. So I almost think like it should be terrible threes, but the behavior is very challenging because this child is becoming more independent as they're growing, which is a beautiful thing, but learning how to navigate that is hard. And so understanding those behaviors and having a home visitor teach those behaviors and maybe how to navigate them is a huge benefit. Learning about nutrition and healthy eating really helps reduce health problems like diabetes in the future years. It really allows children to gain appropriate weight. And these are all positive impacts on our families, but really also on the future of our healthcare system. If we're using preventative measures, we can all benefit from this. You know the saying, it takes a village, and it really does. Having the additional support is incredibly valuable, especially in those first couple of years. This picture is when I went to Costa Rica, and that is my mother, my Costa Rican mother, who was the bread maker for the community. And this is her with the community making the bread. She would teach the children how to make the bread, and it brought everyone together. And this is reducing that isolation that I think so many parents experience, and it was beautiful. And my last slide is just a personal slide, but it kind of goes back to this journey. After 30 years, I went last month back to Costa Rica to the same village that I had experienced when I was 17. And this picture is of me and my two Costa Rican sisters who welcomed me back in with open arms. They had the typical gallo pinto, which is local beans and rice. And they had the homemade tortillas waiting for me. The whole family was there. There was the grandparents, the parents, the grandkids, the cousins. They even corrected my Spanish as they had before to help me learn so I could become better. It was just incredible and it was beautiful. And so that was my incredible journey to this. But in the end, this is what brought me to understand community. It brought me to understand home visiting, community outreach. And it's a really, really important part of my personal journey, which is why I value it so much. And I thank you all for joining me on this journey.
Great. Thank you, Dr. Williams. That's wonderful. I just struck again, as I am every time we have interactions and talk, and just how lucky we are at Firstborn to have a medical director that really gets the home piece of it, the community piece of it. And, just to highlight, like you said, we are able to have you come and talk with staff directly every quarter to talk about relevant questions that staff have. Dr. Williams from New Mexico, so to be able to ask a pediatrician from New Mexico about what's going on for New Mexican families, I think is really special. And as we've gone through and edited and are always reworking our curriculum, Dr. Williams does review every piece of curriculum for accuracy and for information that's going to be best for families. So I really appreciate that. And I'm so glad that you're on our team. One question did come up that I think is really useful, especially a lot of the folks here today are home visitors or involved in that end of the work. I hope folks that are from the medical community can, see this video after the fact in those little moments that people have from clinics who are so busy and have schedules that are a lot harder to work around. But for today, and the folks that are here, like if people aren't already connected with their medical providers in their community, what do you think are the best, like what do doctors really want to know? Like if we were going to try to bring something to a doctor to bring that relationship closer, what are things that doctors might want to know from a home visitor?
That's a great question. And I think it depends on the community and the clinic. And so I don't think I have a specific answer for this, but, looking at some research models that have been done in the past, there's been clinics that have decided to integrate home visiting programs into their clinics. So there's an ability for the home visiting program to go either to the home or to visit that family in the clinic setting. And I feel like that that model would be wonderful to have everywhere in every clinic. Not that that's possible, but I think the idea would be to have a meeting with the clinics that are in your local community, understand how there can be more of a collaboration between the medical community and the home visiting community. The biggest pieces that I think we in the medical community struggle with, which was on that side of time, resource, and community, is that we have these wonderful screening tools, and I think the issue is finding resources when there's at-risk children, and that's where I feel if you're seeing developmental cues that are delayed or risk in social situations that you're concerned about that have probably either not been brought up in the clinic, those are things I think providers could really use information on, and maybe being able to reach out to more resources and community parts for that. So I would say social issues, developmental issues, all of that. I think if there was more of a collaboration, and I think if all of us brought together what resources are available in our own communities, maybe we could do this as a team as opposed to individual pieces.
Great, thank you so much. Something to think about, like we could take the next frontier of home visiting into clinics. And like I've mentioned, I think before this week, the FOCUS program in Albuquerque does have an integrated early intervention program and clinic. It's the only one I know about in New Mexico at this time, but there's a lot of strength in having all of those folks come together and support families. So thank you all so much for coming and joining us again today. It was wonderful to see you. Madi will try to drop in the chat as folks head out just some of the links to stay connected with us, get the links from the conversations today. If you know anybody who would be interested in this conversation, if you've got medical folks in your community who might be interested, please do pass along the links as you get them. We really do want to use this session today, especially to involve medical providers and help them to understand the benefits, just like Dr. Williams outlined. So thank you all so much. And thank you, Dr. Williams.
Thank you very much.